in general. So this morning we're going to talk about ABGs. This is going to be part review from Major Johnson or Colonel Johnson. And then if we have time, we'll do afternoon's lecture too, which is on pulmonary function. So this morning, first lecture we're going to be chemists, and the second lecture we're going to be mechanical engineers. These are both tools that we use to assess. So when we have patients come in and they have respiratory complaints or they have respiratory symptoms, we've talked about our physical examination. That's one tool we have. We've talked about, well, not a ton of labs, right? Pulmonology doesn't have a ton of labs, but this is one of them, the arterial blood gas. You'll hit this topic again when you go to your nephrology lecture in senior. But ABGs is another one that we'll use, and the last tool that we'll discuss in this lecture before we move on to start talking about actually pulmonology will be our pulmonary function test. So that'll be another tool. So a bit of a review for the ABGs. We'll do some, try not to look at the examples. I keep forgetting to take them out of the lectures I posted, so they're more fun. So try not to skip ahead to the end because we have some examples. So we'll get into this one real quick. Basic terminology, FYI. Remember what acids are, what bases are. Our acids are hydrogen protons with a little plus. Our bases are going to be our OHs in general. So they donate electrons. The buffer, so in our body, I'll show you a little chart where it shows you the things that you put in your body that are outside of the normal pH that the body functions, work in. We introduce those things to our bodies all the time. When you do a 2-mile run, your body is full of lactic acid. So your pH will shift out. Now, it won't become a medical issue because the body has a system to counteract that. One of them, which you'll find we'll talk about, is increasing your ventilation rate, right? After that PT test, right? And you're blowing off hydrogen, CO2, to help get the acidity down in your body. So that's one function. Another way, we have these little proteins in our body. Hemoglobin helps with that. Carbonic acid, that's going to be the big one that we test and measure in our ABG. But these are all chemicals in our body that help to regulate our pH. Remember, the pH needs to be there because outside of normal pH, moderation is the key, right? There's such thing as hyper and there's such thing as hypo, and both are bad. If you look at anything in medicine, too much of a good thing, not enough of a good thing, both of them are associated with pathology. Too much vitamin D, not enough vitamin D, things like that. So the body has this amazing system between the mechanics and the chemical functions to keep our body in this nice range. Kidneys are amazing organs. We'll talk about how this affects the lungs today. Again, just to reiterate, oxygenation is getting O2 in the body, and ventilation, ventilate out that CO2, that acidic CO2. All right, so we kind of already talked about this stuff. We want the body to be in a normal pH. It can dance outside of it, but we should be able to bring it back into a normal range. So, important processes that we need to consider. So there's our 2 main modulators. We talked about those. So we can either affect that with our respiratory system. CO2 is slightly acidic, so if our body becomes acidic for whatever reason, we start to breathe faster to try to vent off that acid. That happens fairly quickly, minutes to hours. The renal system is a little bit slower. It relies on a few more systems, but it affects by reabsorbing HCO3. And HCO3 is basic. We've got these 2 systems in our body. One works pretty quick. You can see changes within hours and minutes. One works a little bit slower. So here's our compensation, right? So first response, so you take a PT test or you do a crazy workout and your body becomes acidic because of all the lactic acid. So right out of the gate, we use our buffer system. Some of those proteins, some of that bicarb already in our system to try to buffer that. Or vice versa, right? Some of the acid in our system to buffer it to be more acidic. So this is the process. It's a little bit slower. So the kidneys will respond by either retaining more bicarb. So if you're acidic, it'll start holding on to bicarb, or it will increase elimination of it. Here, we'll hyperventilate to try to blow off that CO2, or we'll slow down our breathing to try to retain that CO2 in the body. So this is the little chart I referenced. You know, obviously, don't drink battery acid, right? Don't drink liquid drain cleaner. Don't drink bleach. You know, those things are all bad. That's why we had that Mr. Yuck sticker back when I was growing up in the 19s. You know, where we had to start protecting our kids from these things. But look, lemon juice and vinegar. We do that stuff all the time. My mother-in-law took the enamel off her teeth because she was addicted to grapefruits, right? She ate them so much that she actually lost the enamel off her teeth. Have you ever heard that thing where you put a tooth, you have a tooth lying around, put it in a 2-liter bottle of Coke, and it'll dissolve overnight. So very acidic things that we consume on a daily basis. Right? So here's our nice neutral pH. We like it right there. So just keeping in mind, our bodies move in and out of normal range. It's like the perfect blood pressure, right? Our bodies are going to move in and out of normal ranges all day. It's just making sure that we get out of that and back to a place where our body can function properly within a correct range. So we're chemists and we're mechanics when we practice medicine. So we'll talk a little bit about oxygen transport. So again, this is the chemistry of respiration. This is the chemistry of oxygenation. Next lecture, we'll talk about the physics of moving air in and out of the lungs, but right now, we're going to talk about getting oxygen to the tissues and how that affects the pH as well. So oxygen saturation, and that's how much, so we talk about partial pressures, SpO2s, things like that. That's how much oxygen is in that hemoglobin. And that depends on a few things. So how much oxygen can be carried, obviously, you know, if you're anemic, you're going to carry less oxygen, things like that. But how much each molecule can carry, these are the things that affect it. So pH, partial pressure, PCO2, temp, and then something called D2, whatever. We're not going to worry about that one. That's a Colonel Johnson baby, so it will not really affect you clinically. This is probably the only time you're going to see it. If you're on Jeopardy and you remember it, good for you. But these are the things that affect it. So these are the things we're going to look at. So depending on what the pH is in the body, what the temperature of the body is, and what the partial pressure of CO2 is, will affect how well your body is not only able to get the oxygen into the tissues, but or into the lungs, but how well it gets it to the tissues. It's got 2 trips to me. The heart plays a role in that too, mechanically. All right, so this curve, I feel like this is probably one of my blue boxes, but we'll go over that when we do the review. But we have this thing called a left shift and a right shift. Is that new terms for you guys? Old terms? Something you've heard before? Okay. So left shift and right shift. Got this pretty picture here. So we talk about when the body is alkalotic, the pH is increased outside of normal range, and the hemoglobin holds on tighter. It's great in the lungs because it picks it up real nice, but it forgets to let it go. You need to have that diffusion. Remember we said that in the last lecture, it's diffusion, requires diffusion. So it's holding on too tight. So again, it picks it up great, but it won't let it go when it gets to the tissues. So when its pH is up, body is more alkaline, hemoglobin holds on to the O2. And then when the PCO2, the partial pressure of CO2 is down. That also creates a left shift, and then when the body's temperature goes down. So little girl holds on to the teddy bear, oxygen infinity, right? We want to be in here, and when these things occur, we go too far to the left. So highly bound, can't let it release into the tissues. Vice versa, right shifts, when the body becomes acidotic, or the partial pressure of CO2 goes up, or the temp goes up, then it doesn't hold on as tightly. So it doesn't pick it up as well. It lets go in the tissues great, but it doesn't pick it up well. So I have a little question for anybody that's done trauma before. So we're talking about, decreasing the temp, increasing the O2 affinity. Like, that's a good thing. You'd think in trauma that we would want that, right? So why do we keep bodies warm?
Offload the oxygen to the tissues to 6 to 9.
So am I hearing? I'm hearing the triad of death, right? Right. So this is one of those. Based on the information, it would make sense to keep them warm based on this, but in reality, there's another force at play in trauma, which we call the triad of death, which involves hypercoagulability, and so keeping bodies warm actually improves outcomes. So it's just one of those things in medicine where it doesn't make sense on books, but in reality, this is what we do, and it works. All right, so now we're talking about the other. So now we've done the whole, magic in the tissues, and now we're talking about that CO2 coming out. The CO2 is coming out. Now it's carried as bicarb. Bicarb is our alkaline compound. This is the one we measure when we measure ABGs. When we take that blood out, that arterial blood, we're measuring our bicarb. That's the alkalinic component of our equation. And again, constantly shifting within the body between these three compounds. And then these are just two other ways that we carry the CO2. It's either bound to the heme or it's dissolved in the free plasma. But this bicarb, the reason we highlighted it, is this is the form of carbon dioxide. It's the most common form in the blood, and that's the one that we actually read when we measure ABGs. All right, so the arterial blood gas, one thing I want you to know is that you will never see this ordered to make a diagnosis. Someone won't be like, an ABG of 2 means they have a pulmonary embolism, right? That is not what this is for. It is not technically diagnostic. It shows the severity of a person's condition. So a patient comes in, they're tunded, somebody picks them up off the street, you're thinking overdose, Narcan, they're hypoventilating severely. And so you want to assess, you're going to give them Narcan anyway, right? But you want to assess how severe their respiratory depression is. You don't know how long it's been going on, you don't know how much potential damage has been done, or how aggressive you need to be in resuscitating. So it can help tell you how severe it is. When I was in trauma up at Harborview, we used it very commonly. The ER doc would want to get it initially for any kind of patient we had concerns about respiratory-wise, and then he would mainly do it to create a baseline. So when we made interventions, it would help us understand whether or not it worked, especially if the patient wasn't regaining consciousness. So someone comes in, they're tunded, we think it's a heroin overdose, we give them the Narcan, they have not regained consciousness per se, but we want to know if it's made a difference, whether or not they're breathing more. So again, not to make a diagnosis, but you'll order these a lot in the trauma to assess severity, see how aggressive you need to be, and then see if what you did made a change. And these are ordered frequently when you have someone on mechanical ventilation. Again, they can't tell you, you're breathing for them, you're checking their renal function, you're checking all their organs, but that stuff's a little delayed. So you want to kind of get, how is the blood? How is the pH? How well are we doing at oxygenating this patient? And the ABGs are very useful for that. when we would get them in the trauma bay, that was a, here med student, walk down the hallway with this and go straight to the lab and stand there and wait until they give you a little sheet of paper, and then you walk back and you're trying to remember how to interpret them on the way back. So very quickly, you want to get them, you want to put them on ice, and then get them down to be read. And they'll give you a little, literally like a receipt. You'll walk back down, talk to the trauma doc. Don't think we have these. We may have them in roll twos. All right, so this is FYI, so I don't want you to memorize this chart. As we go through these though, I want you to start looking at some themes, and in your mind, we'll focus on the respiratory things, right? So these two categories here. But in your mind, you think about anything that causes someone to hypoventilate, that means they retain CO2, and therefore your pH goes down, it becomes more acidic. You're retaining CO2. So anything that causes you to hypoventilate. You breathe slower. So you overdose on heroin. You have a neuromuscular condition, right? Those progressive neuromuscular conditions where after about 6 to 12 months, the decision has to be made to put someone on mechanical ventilation, right? This is what happens is a patient develops hypoventilation to the point where now they're starting to become acidotic. That's a little bit slower process. Patients who have pneumonia. So anything that causes someone to not be able to ventilate as effectively will cause respiratory acidosis. So alkalosis, and we've got this little mnemonic. Someone hyperventilating, I think anxiety is in there, right? So someone who's breathing too fast. Someone whose vent is set too low, right? We'll talk about vent, we'll talk about having to adjust the respiratory rate. Too high, sorry, it's not too low, it's too high. Blowing off too much CO2. And then some chemical causes as well. But again, don't memorize this. Just think hypoventilation, blowing off too little CO2 causes acidity, hypoventilation or hyperventilation, blowing off too much CO2 causes alkalosis. These are our things that we're going to measure. I will give you the normals so that you can compare them. So the pH, we'll get the PaO2, which I'll tell you when that's useful is when you know you have an arterial sample, would the O2 be higher or lower than the CO2 in an arterial sample? Higher. So what if it's lower? Yep. If it's lower, you'll be like a stud, right? Because you would assume that when you got arterial blood, it would be nice and bright and red, and it would just shoot out into that vial, and vice versa. If you've ever done phlebotomy, a venous draw would be darker and slower, and you would assume that. But sometimes people that are very, very sick, they may have low O2. Their arterial blood might not be pink, bright red, pulsating. So, but if you do see that they're flipped, where you would assume that the O2 is going to be higher than CO2, you need to consider that you got a venous sample in them. And you have to redraw. Because all of our normals are set up for arterial blood. So we'll teach you one way to analyze these. We'll do some examples. This is the data that you're going to get. So this is an actual example. So this is like that little receipt tab that you're going to get. These are the three you're going to focus on. The next several slides are just a bunch of charts. If you have a good way to do this already from your biochem, just use that. There's a million different ways to look at these. This is one way that I teach or one way that I understand it, but use what works for you. It all gets you to the same answer if you use the tools properly. So right away we're looking at, that gives you some other stuff, that's really nice too, right? But right away we're going to look at our pH, our PCO2, that 35 there, and our bicarb. Those are going to be the three that we use. Again, I'm sure you've learned the roam. The roam is one way to do it. Just pick a tool, whatever works for you, and use it. So, very important. I'll just say this up front. This is something I see people get hung up on. Even if the pH is normal, check the other two. Even if the pH is normal. If you get to the pH and the pH is normal, that doesn't mean that's a normal ABG. So I'll leave it at that. I've done that before. I've made that mistake because their body may have been able to compensate to get that back into a normal range, and actually your HCO3 and your CO2 are still out of normal range. So make sure when you interpret them that all three have to be within normal range, and then you can say normal. I like to ask normals on tests. So just take the test, read the questions, do your thing. But if you're like, don't trust the normal, you can trust the normal. I like asking them because that's what you're going to get most of the time in clinic. So I don't want you to have to always think you're looking for pathology. So number 2, right? If any of them are abnormal, then you go back to that pH. And I know we said 3.35 to 0.45 is normal, but in order to do the interpretation, you have to pick an actual midpoint. So you pick that midpoint at 7.4. If it's less than that, it's acidic. If it's greater than that, it's alkalotic. Then you switch over to PCO2. Now, PCO2 is acidic. Right, so the PCO2 has moved in the same direction as the pH. Or excuse me, the PCO2, see it, if this confuses anybody, I apologize. So I just totally said it backwards. So if it's acidic, so if the PCO2 goes up, we would assume that the pH is going to go down. And then we look at the HCO3. So HCO3 and pH both going up means metabolic. PCO2 and pH going in the opposite direction is respiratory. Compensation, I will not ask you about compensation, but I think it's important to understand the concept. So fully compensated is when the PCO2 and or the HCO3 are out of range, but that pH is normal. We see that with chronic diseases like COPD, right, where a patient is constantly hypoventilating because they can't move air, and so they're retaining CO2, and so their body is always a little acidic, and after a certain amount of time, when this has been going on for a period of time, the kidneys will upregulate the retention of bicarb. And so even though someone has a normal pH, it is because the body has had to compensate for that. And then you have somewhere in between, right? You see the bicarb, so the carbon monoxide is high, it's acidic, right? So it's 7.3. The CO2 is high, it's 7.3, but we see the bicarb's high too. So the body's trying, it's partially getting there, it just hasn't gotten the pH back to normal range. So that's partially compensated. Here's a chart, I won't go over it, because I'll probably say something backwards. If you guys need any help with this, if you want to go over them, I have some examples at the end of what you're going to see. Again, normals will be provided on the test. So we'll start with an example. And I forgot my candy, sorry. Don't look ahead if you can help it. There's a 7-year-old male, ankle fracture. His vital signs are normal. We get an ABG. So we start with a pH, normal or out of range? Normal. CO2, HCO3, so it is a, yep. Okay. I know, guys, I'm not trying to, I do this more for myself, so they're easy for me. Okay, so that's a little example. Good. All right, 35-year-old female, heroin overdose. So she is probably hypoventilating. She's probably retaining CO2. So if you had to guess, would she be acidotic or alkalotic?
Acidotic.
Say it again? Acidotic. Yep. Yep. It's counterintuitive in my mind too. But as the acidity goes up, that pH drops. So you would expect her to be retaining CO2 because she's hypoventilating because she overdosed. And that's exactly what we see. Somebody's acidotic. Then we go to the PCO2. Is that high or low?
High.
High. So pH went down, CO2 went up, so is respiratory. Yep. And then it looks like the kidneys are trying. Maybe that's high normal, right? So maybe the kidneys, maybe she's been overdosed somewhere for 6 hours, and the kidneys has started to hold on to more bicarb. So it's trying, but really what we need to get this girl to do is start breathing again normally. Maybe intubator, right? So we can deliver that oxygen ourselves, gently. But she can't stay like that for very long, or the biological processes in her body will start to shut down, including her ability to carry oxygen effectively to the tissues, which is what causes a lot of that organ damage. All right, 20-year-old male, pilot trainee. We're doing some training. He's breathing really, really, really fast. He's gasping for air. So he's just blowing off that CO2. I don't know why they got ABG on them, but they did. All right, so we start with the pH. Is that high or low?
High.
High. So they're alkalotic, right? PCO2, high or low?
Low.
Low. So they're blowing too much off. And then our bicarb, normal. So this is fairly acute, so we wouldn't expect to see any changes with the bicarb here. So this is respiratory or metabolic? Alkalosis or acidosis?
Alkalosis.
Good job. All right, so that was a quickie. We can start talking about PFTs and get the 1500 lecture done. Nice.
Do it.
All right. So this is going to be the last tool, and when I say tool, something that we have in our little toolkit to order, right? Like our chest X-ray. That's something we can use. Our ABG. Later on, we'll talk about something called a D-dimer, right? CT scan, CTA, EQ scan. So this is another one. This isn't like ABG is more of an acute urgent study. This is not necessarily an acute urgent study. This is something that you order in a routine nature. And it really has more to do with, I guess it's more like an echo when you think about the heart. It's more to test the physics of the lungs. We'll talk about the different volumes, we'll talk about the different capacities, like we talked about CO2 and pH and all that in the blood. And then we'll transpose those into reports that you're going to get from these tests. And then we'll talk about how to interpret them, how to use them, when to order them. I think this lecture is a little longer, so we'll take a break. Just throw something in there, right? It's only 10:30, so we're good. All right, so here are, so we talked about, remember we talked about the oxygen dissociation curve. We gave a little background, a little scientific concepts of what's going on in the lungs. Again, the heart, it's a muscle, it pumps, it's got valves, so that's the mechanics of the heart. It's very, it pumps, it pushes, it pumps, it pushes. The lungs are a little bit more nuanced. There's different volumes, there's different pressures. Remember, this is air flowing in and flowing out. We're changing pressures. There's a little bit of neurochemical control there in our small bronchioles. A little bit of both. There's 3 factors that we'll talk about when we talk about lung function. The first one is the lungs need to be elastic enough to go like this and go like this. It has to be elastic enough. If it gets too stretchy, then it can't recoil, and if it gets too tight, it can't fill up. So the compliance of the lung. When we talk later about some different pathologies, then we'll understand how this ties back into why aren't the lungs doing what they're supposed to be doing. So pulmonary fibrosis is one of the diagnoses we're going to talk about. The lungs are too stiff. So they just literally can't fill up with air, and that's going to overall decrease the function, which the function of the lungs is primarily respiration, oxygenation, and a little bit of acid-base balance, right? So it describes how much the lungs can inflate. So when we talk about emphysema, we'll talk about pursed lip breathing, where patients actually don't have the recoil they need, so they actually breathe like this to try to decrease the diameter and actually change the physics of it to try to be able to get air out. Because again, you've got a diaphragm and you've got these intercostals, but that really on itself doesn't really pull air in and push air out sometimes enough for people, where you actually have to, manipulate your airway a little bit. And I think I fixed this. Yes. And then I call normal volula, that little zone of exactly where you want it. And then in medicine, we learn about how to manipulate people when they're not in that range, right? Give them bronchodilators, give them high blood pressure meds, things like that. We want to get them into this nice zone where their organs are functioning normally, even though they've desperately tried to destroy them throughout their entire life. The second one, so we've got compliance, now we've got resistance in the airway. Again, going back to physics, anyone who does any type of physics, comes from any type of physics background, this makes sense. In order to move things, you need to have a certain amount of resistance so that whatever you're moving through it is able to go from A to B. So the resistance, the change in pressure to get that flow going through. Alveoli patent, right? You need to have a certain amount of pressure in there to hold those alveoli open. And then every 90 seconds, you actually take a little sigh to help that even more. So normal airway. So if you look at this curve here, here's when you're breathing in, and then that first few seconds of exhalation, you're blowing out a majority of the air, and then it starts to taper off. So the volume here, that's the total amount of air moved in and out of your lungs. And then this is the flow. So it goes really, really fast. This is where you're measuring those large airways, right? The bronchioles, the bronchi, the ones we'll talk about when we talk about COPD and asthma. And then here is where we talk about, those smaller airways. This is that last little bit of air eking out. Just a little note here on beta agonists. We will talk about those when we talk about asthma, so I won't talk too much about it. The last one is the stickiness. So there needs to be surface tension within those alveoli to keep them patent. So you can't distribute, right? You can't distribute those oxygen molecules to come in contact with the organs within the alveoli that actually exchange it if the alveoli are collapsed. So you need to be able to keep those patent. When we talk about neonatal respiratory distress syndrome, that is when children are born premature, they don't have enough surfactant, and those alveoli are all collapsed. And so there isn't that surface area, the oxygen's going in and out of here, it just can't get to the part where it exchanges for the CO2. And when these collapse significantly, that shows up as what's called atelectasis on a chest x-ray. Part of that lung has collapsed. All right, so this is FYI. We'll go over the review. There are some of these that I might Most of these we're gonna have to know anyway when we talk about the actual PFTs, but I don't want you to just memorize this chart. I'll tell you what you need to know on here. So capacities, volumes. So these are just, again, in medicine, we make up these words so that we can communicate effectively about different functions. So if you look, start all the way to the right, this is all the air that the lungs can hold, total lung capacity. That is not the same for everybody, right? There's a huge difference between pediatrics and adult, but in terms of straight number volume, that is everything that your lungs can hold. We squeezed all the air out of them and then completely filled them up, whatever that volume is, that capacity. So that's made up of, I'm going to focus right, that's made up of several different volumes. So we've got everything that you can inhale. So if you're breathing along here, this is normal eupnic breathing. And then you blow everything out. And then you inhale everything you can. And then you get back down to normal. So between blowing everything, between your normal tidal volume, everything you can blow out past that, and then this inspiratory reserve volume, those three, those are your vital capacity. Your forced vital capacity is one of the things that we're going to use when we do our PFT calculations. So it's all of the usable air within your lungs, how much air you can move in and out. This little one down here, that's called your residual volume. That will take a special test to measure. The residual volume is the air left in your lungs after you've fully expired all that air. You need to leave a little bit in there, right, to keep those alveoli open. You never completely get rid of all that air. Well, at some point you do, but that's later. All right, so the lung volumes, we will directly measure these. Your tidal volume, again, that's this little wiggle line between when you start to just breathing normally, before you go, or if you're breathing normally before you try to blow all that air out to the bottom. So that's your tidal volume. Your inspiratory reserve is anything you can inhale over that. Your expiratory reserve, anything you can exhale beyond that. This is another term, the FEV, forced expiratory volume. So this is a dynamic volume. That means we're measuring it, we're measuring the volume in a setting where the patient is actually forcefully blowing out that air. So how much air can they get out after they fully inspire? How much air can they get out during that forced expiration? Usually you have to do it for about 6 seconds to get all the air down to back to your baseline. The FEV1, so after 1 second, remember in that first second, most of the air we're measuring is coming out of those larger airways. So the FEV1 is a specific measurement, and in theory, it's supposed to measure the patency of that larger airways. So when we talk about things like COPD and asthma, which are medical conditions that are associated with obstructive airway disease, this FEV1 is going to be an important measure in terms of making those diagnoses. Residual volume, again, we already talked about that one. So we've got the total lung capacity, we've already talked about that. That's going to be your vital capacity plus the residual volume. And then all these other little words, right? Like understand in general how these are calculated. The ones that I really care about are the vital capacity, at least for the volumes. You know, what does that include? And then understanding that what's left over after that is the residual volume, which is something we cannot measure with our PFTs. We'll talk about that. All right, so total lung capacity, vital capacity. All right, so here's the testing. So we're looking at volume, our vital capacity, right? Inspiratory reserve, tidal volume, expiratory reserve. That's our vital capacity. And then how quickly, that's a dynamic function, that's our FEV1. So forced expiratory volume And we hit the button at 1 second, and we take that measurement. So the how much tells us something about the compliance and surface tension, and the how quickly tells us how much resistance we have in that tubing. This is a standard pulmonary function test. Sometimes these can be done in the clinic. Most of the time, I've been at little tiny med-ex for some reason, and I always have to send them somewhere to get these done. So this is a standard PFT, aka spirometry. Most of the time when someone says PFT in a primary care clinic, they mean spirometry. So they mean this first test right here. Patients go in, they're off all their medications. You've referred them because they have symptoms. You think maybe they have COPD, or you're already treating them for COPD, right? And you want to see how well your treatment's improving their symptoms. They failed their PT test, they're getting chaptered out. You do their chapter physical, they say, yeah, I get real short of breath. You're like, no crap, so why? But as part of your chapter physical, you send them for PFTs because they had symptoms. Which I had a patient do that, a soldier do that. Her PFTs were positive. She was unfortunately still chaptered out because she was non-compliant with therapy, i.e. she kept smoking. Well, and it was kind of a weird thing, you know, because she could have easily, because in order to stay at least in the Army, you have to be able to pass the run. So according to 40-501, you can have asthma and be in the Army, but your medications have to support you such that you can pass the ACFT. There's a little bit more to that, but you can't do an alternate event with asthma. But you can stay in if you can do those two things. So she never achieved that, but it wasn't because we failed to treat her effectively. So it was just, I don't know. It was one of those where there was I don't know why I fought it, but there was something about it. So this last one, okay, so these full PFTs, this is where we're going to talk about that body plesiomography. So there are times, we'll talk about them, when knowing how much air is still trapped in those lungs is important clinically. So say they have, you know, crappy PFTs, their volumes are terrible. So the question is, well, how much air is actually still trapped in there? Because if there's a lot of air still trapped in there, that's more consistent with something like emphysema. Versus if someone's got severe pulmonary fibrosis where that lung tissue has just been replaced by a bunch of fibrous tissue, then that residual volume won't be high. So that'll be, again, this will be more of a specialty thing, but that's where that body plesiomography comes in. I don't know if everyone has ever used these peak flow meters. They're kind of going away in fashion. I don't think PEDS even uses them anymore for asthma. I think they're useful to see a lot of asthmatics. It's kind of like checking your own blood sugars at home. We'll talk about those a little bit coming up when we talk about asthma. And then our good old pulse ox. We'll have like a couple slides on that. Because that's a special, it's got some special things about it. All right. When you do an EKG, pretty much your results can be interpreted regardless of knowing a ton about the patient's demographics. Here, it's a little bit more important because the normals are based off of the patient's age and a couple other things. So that's important information. Just keeping in mind that if you look at 10 different PFTs, the normal values will be different. So we predict them based off of the patient. Again, we'll call it spirometry. I will not call it PFT so I don't confuse you, but in practice, someone will say a PFT, they'll mean spirometry. But for spirometry, these are the values that you're going to be given. I'll show you what that looks like on an example. And then again, our residual volumes only be measured through that body plesiomography. So you will not get something on your PFT that discusses residual volume at all. We'll just be talking about tidal volume, the inspiratory reserve, the expiratory reserve, and that equals the FBC. And we put the F in front of it because when you do a PFT, it's dynamic, so it's a forced vital capacity. But that's going to be important. the FEV, so how much air you can get out in that 6 seconds of, right? And then the FEV1, which is going to be a majority of that air, because that's the air you're pushing out of that big airway. That's that initial air. So that will, FEV1, that's going to give us a lot of information about any obstruction in the airway. Evaluate for underlying, okay, so this is why we use them. So somebody has symptoms, and you want to know why. Does it have anything to do with their lung function? Do they have obstructive airway disease? Is there something going on in the actual lung tissue itself? Obviously, you're going to get this probably after you get a chest x-ray, right? Because that's really our first one. Also, we can determine severity. So how bad is this person's asthma? We'll talk about asthma a little bit. Knowing what their PFTs are does play a little bit into what medications you're going to give them. And then pre-ops, you'll talk about that when you do your surgery course next semester. Sometimes we'll get PFTs for certain patients who are having certain types of diseases, or patient with COPD is having open heart surgery. We'll do a pre-op PFT, and then a lot of opt-health type of stuff too. Disability evaluations, and that was the girl that was getting chaptered out. The whole point of the chapter physical, right? To figure out if there's a medical reason that this person is not able to fulfill their requirements. When do you not do them? So this is more for the actual tech when the patient comes in. These are more acute things. Important to know nonetheless. It makes sense, right? Someone comes in, you are going to be having them perform dynamic breathing functions. So someone that's trying to forcefully expire, that's in an early asthma attack, you can push them right into a severe one. So these are things when you go in to get your PFTs, check it out, go in, see what the form looks like. The more you know about the stuff you're sending your patients to, the better. But these are things that they're going to check off when you're sitting in the room filling out your form before you go in. Are you having any chest pain today? Are you having any difficulty breathing, etc.? Have you been diagnosed with tuberculosis, right? That's a bad one. So all these things, performing this study will potentially cause worsening of them. Not to mention we give them bronchodilators while we're doing it, so that's not good for someone who's having angina. Limitations. So it requires, never mind. I'm going to tell my breathalyzer story, but it takes, you need good effort. So PEDS is kind of a difficult one to do. So I always say like subjective things, the self-report, you have to use them with a grain of salt. So patient effort, sometimes people will send back reports and be like, patient effort wasn't there. So they don't want to give you results that you're going to act on if they don't feel like they got a good study. So a lot of the tech's job is to get patients to, like the cop is trying to get you to blow in the, and you're like, no. So you got to have a good, all right, let's take a break and come back at 11 and we should get done by lunch. Talk about the PFTs, again, this is a study that we will be sometimes sending patients to get. We talked about the indications for it. We're evaluating symptoms. We're evaluating how well we're treating a known condition. We're going to go through and talk about the technique, what the results show, and then how do we interpret them. Throughout the rest of the course, we will have different disease processes where PFTs will be part of the diagnostic criteria, i.e. it'll be a clue in the question of what the answer is. So asthma and COPD, obviously, those are going to be our obstructive. And we talked about some other examples. So it'll be one of the things, if you understand them, that will help you when it comes to answering a test question, but more importantly, treating a patient. All right, so here's our spirometry. Here's the technique. They measure it breathing normally. The tidal volume is one of the volumes you're going to get. They'll measure inspiratory reserve directly, and then they'll measure expiratory reserve directly. All those added up together equal our vital capacity, right? So FVC. All three of those. So these are measured directly, and then we translate that on our little printout into the vital capacity. When it's dynamic, and they're breathing and exhaling in a forced manner, we call that the forced vital capacity, or the FVC. All right, so we got to make sure that there's enough, it's long enough, again, in the back of a cop car, do a breathalyzer, right? It's got to be, you got to keep blow, 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 blow until you get that full 6 seconds. We want to get as much air out of the lungs as possible, because that is the expiratory reserve volume, and that is part of the FVC. So we're talking about how much air can fit inside someone's lungs. And then adequate effort, it must be forced, it must be hard and fast, because we're hitting that mark at 1, and we want to have a good measure of how much air they can move in and out of the conduction system, right? We want to look for obstruction. And then make sure they're clean breaths. All right, so this is, you will see this again, but this slide in particular is just nothing, I'm just using it to introduce some concepts, so you don't have to spend a lot of time on this. Anything that's important on here will be rediscussed later on. So this is a normal flow loop volume on the left here. Again, you start here, you inhale, and then you blow. So, inspiratory, expiratory. If you go from here to here, that's the volume. Right? If you go from, if you look at this part of it, that's the flow. So this is normal, peaks and then tapers off. We will talk about what happens when we have problems with the flow, which translates into obstruction, and how that affects the flow loop curve. And this is just a different way of looking at it. And it shows you, here's the volume, shows you, you almost get all that air out. Again, here's the volume now, flipped on its side, and you get almost all that air out, or you're supposed to. A normal lung will get almost all that air out with the right effort in the first second. And this is where we set a hash mark, and this is what's recorded on our PFTs. So we're getting this volume, which is our vital capacity, and we're getting this measurement, which is our forced expiratory volume after 1 second. And between the two of those, we should be able to say whether or not it's normal function, whether or not there's something wrong with the flow, there's an obstruction problem, or whether or not there's something wrong with the actual volume of the lungs, or our vital capacity. All right, so then this is the flow volume loop. This is what it looks like. Early numbers are going to be our larger airways, and later numbers are going to be our smaller airways. We've already kind of talked about this. So forced vital capacity. Remember, we're looking at compliance and stickiness here. So we're looking at the lungs' ability to expand and fill with air. The lungs themselves, all those little alveoli. If you've ever seen a lung during a procedure, you know, it looks like a little octopus. It kind of fills up. It's very, very lubricated. So we're looking at how much space, how much volume is actually able to fill up with air. How much of that lung is compliant enough and sticky enough to receive that air. And it's the total amount of air the patient can rapidly blow out after inhaling as deeply as possible. So things that affect the FVC, so when you get your report and you see the FVC is abnormal, the things that can affect that, either temporarily or permanently, are things like pneumonia, right? Part of the lung is filled up with pus. You've got a lobar pneumonia, or purulent material, right? So you've got that area where air can't get there because there's a consolidation in there. That will decrease your FVC, hopefully temporarily, because you'll diagnose it and treat it. Fibrosis, we'll talk about fibrosis and sarcoidosis. Those are more permanent conditions, where the parenchyma of the lungs are replaced with tissue where they can no longer receive air to oxygenate and respire. And then sometimes the lung can't expand because of things external to the lungs. Severe spine deformities, right? We'll talk about pleural effusions, obesity, right? So much weight, external weight on that chest wall that patients just have trouble breathing. All right, so then here's our FEV1. Two different ways to just view that volume, but this is the volume that we're measuring. Here and then here. It's just two different graphical representations of the same thing. And this measures flow. So how much air can you get out in that first second with good effort? So this is looking more at our bronchi and our bronchioles. So if it takes someone a long time to get that air out, we worry about things obstructing that airway. And the two most common things associated with the FEV1 being abnormal are asthma and COPD, which we will spend whole lectures on. Go ahead.
Will they have that FEV1 like time signal for this one always?
No, maybe not, but you'll get it in the report. You'll have that value in the report. No, yeah, right. Usually they won't, and I had to look at that a couple times too. My whole math brain. But yeah, they'll usually won't have this, but you will certainly have it in the readout. They'll give you that in the report. All right, so then we create this thing. Again, we love to create these new terms, these new ways to evaluate medical data so that we can use it effectively in clinical settings, right? We got to come up with this other way to measure things so that when we get data, that it's usable. So we created this FEV1 FVC ratio. And it's just a way to normalize that FEV1 relative to what that FVC is. So we're going to use this ratio in order to make decisions on how we interpret these PFTs. We're still looking at obstruction. We're just looking at flow relative to the whole capacity of the lungs. So the rest of that, I mean, you can read it. It just kind of talks about why we use the ratio versus just the FEV1. We will use the FEV1 later on in the interpretation, but initially we're going to be using the forced vital capacity alone, and then the FEV1 FVC ratio. Talked about all that. All right, so let's talk about this flow loop. Get a little visual concept of abnormalities in this flow loop. Again, we breathe in. We look at the dotted line there. The outside line, the black line. Start over on the right. Start over on the right. We breathe in. And then we blow. And that's how that flow loop gets drawn. That will be on your report. Look at it if you want to. They usually look like crap on the reports, but the important thing is the numbers. Obstruction. So this is one of the interpretations of a PFT, is identification of obstructive airway disease. And we identify this with flow rates. We've already talked about this FEV1 FVC ratio. Again, that will be a value that you are given, and all your job will be to do is to compare that, to know that that's what you have to look at. That's number one. And then to compare that to whatever we determined was the normal range for that particular patient. So this means, again, we have a tubing problem. Bronchi, bronchioles. Something's wrong in that conduction system. So the term we use to describe this is a scooped out appearance. All right, so the volume of air you eventually move is just slightly decreased, right? So I know it's not totally normal, but here it's considered, if it's purely obstructive, which not everybody is, but we consider it close enough that it's in the normal range. It's close enough to the normal. So we've got the volume, the lungs are compliant enough. It's just, look at the sad flow, right? Usually we get all that air out and then it tapers off. Here, it just takes us longer to get that air out. So when we put that tick line at 1 second, it's decreased from what we consider normal. So the volume, the total volume, the FVC, the capacity might be within normal limits, but that FEV1 FVC ratio is decreased. This is how it looks graphically. You hear the term scooped out, but it has this kind of, not this nice straight flow. It has this, doesn't go straight up and down. You don't get as much air out in that first second, and it takes you longer to get that air out at the end. Vice versa, we talk about restricted disease, then we're talking about flow is not the problem. We can get the air in and out, it's just the lungs are not compliant enough, or there's restriction involved somewhere, either in the chest cavity, like neuromuscular disease, pleural effusion, that the volumes, you can't get as much air moved. So that's restricted on that side. Volume is decreased outside of the normal range, but you can move the air effectively. Keep going. All right, so then again, this is not a memorization thing. I'd like you to have a general idea when we talk about the different types of airway disease, obstructive versus restrictive. Again, this makes sense. We look at all of these, we will talk about this one, this one, this one, this one, this one, all of them. So we'll go through all of them. One of the clues on what's the most likely diagnosis is going to be that they have obstructive PATs. We'll know what that means at the end of this lecture. But there's something wrong with the tubing. On the right side, there's something wrong with the air, with the actual volume of the lungs. The FVC is decreased for whatever reason. Either there's fibrosis has replaced the lung tissue, or there's fluid in there. The lungs are no longer, or there's something wrong with the chest wall where it won't allow the chest wall to expand to allow the lungs to inflate. And purely obstructive and restrictive is usually a young person's diagnosis. A lot of these geriatric patients, older patients, when they have pulmonary issues, a lot of them end up with both, right? So we call that mixed. All right, so a couple things before we practice these. We've got this reversibility test. So we'll talk about asthma. So someone has obstruction. That means there's something wrong with the flow. There's something obstructing the air. Asthma, diagnostically, is reversible airway disease. So if I give them an inhaler, I do the study, they've got obstruction, I do the inhaler, and the obstruction improves sufficiently to the cutoff we've determined, then we call that reversible. Reversible obstructive airway disease. That is almost synonymous with asthma. Most people use it synonymously with asthma. On the test, it will be asthma. And on your pants, it will be asthma. I'm sure in medicine, right, 99.9, there's something that also can present like that, but for our purposes, it's asthma. And if it doesn't, most of the time, at least for our purposes, non-reversible is going to be COPD, which we'll have full lectures on those coming up. Provocation test. This is what's called our methacholine challenge test. So this is when we try to actually provoke bronchoconstriction. These are our patients that have symptoms. We think they have obstructive airway disease. They're coughing, they're wheezing, they're having, symptoms that just like almost perfectly sound like asthma. but they take the PFTs, which are not perfect. We don't treat tests, we treat patients, and sorry, the PFTs are normal, but you're looking at them going, I really think you have asthma. Then you do what's called a methylcholine challenge test, so where we actually try to provoke it. We won't go into too much detail about that, I won't ask you to interpret it. Just understand that when you have a patient that has symptoms of asthma, but they forgot to read the book, or the test wasn't that great, or we know that tech's not really good, and so you can't trust the results, this is another test that you can send them for. The other time I've used this, for a patient who swears they have asthma, and I don't think they have asthma. I have asthma. I'm like, you don't have asthma. PFTs are normal. And sometimes, even though it's not totally clinically indicated, and symptoms are subjective, right? I will send people for that because a positive, more evaluation needed, but if it's a negative test, we've done the diagnostic test, you absolutely don't have it. That's the other place that I've used it. So it's a way that you can be objective. And who knows, what if it comes back positive and you're like, wow, I do have bias, I didn't realize that. Right? There's those times in your life you're like, wow, I guess I am biased. Because everybody is. You just have to be aware of it. Alright. That's that, and then we don't care about that. But anyway, I won't confuse you with this one because I want you to think about the other PFTs. Alright, here we go. Let's see where we're at. Alright, we can do it. So interpretation of flow rates. So again, we talked about predicted values. So there will never be, well, I take that back. We'll talk about COPD. We'll talk about where there are, it's not relative to normal. There is an actual cutoff, but we'll talk about why that's the case. But when you interpret these, you're going to interpret them compared to whatever the report says is normal for that patient based off of their age, their sex, and a couple other things. We have this term called predicted value. So you'll see like PRED something. And then we have this term called lower limit of normal. So there'll be a predicted value. This is what you should be. And then there'll be like, here's a little wiggle room, but if you get below this, then it's considered decreased. We don't care about too much, right? It's like LFTs being too low. I don't care. It's like, there's really not something that we get too excited when it's too high. So we're looking at things that are too low. Not enough volume, not enough flow. All right, we got some rough abnormals here. Don't worry about those. Remember, interpretation values will be provided during the exam. All right, obstructive disorders. Got those two. Essentially, when we interpret these, it's going to be obstructive, restrictive, or mixed. Obstructive, that is when our FEV1 FVC ratio is too low. Of course, everybody's got to have their own association. So for asthma, and this is because asthma is a much more diverse medical condition. So they have to use the lower limit of normal for that patient. When you get into COPD, it's usually a very homogeneous group of people, so their normal ranges are going to be about the same. So traditionally, COPD has done their cutoff at 70%. So if it's less than 70% of the predicted FEV1 FVC ratio for that patient, it is considered too low. When we talk about asthma, they're going to use the lower limit of normal because of the diversity of the population of people with asthma. I actually have a case where it's less than 70 but higher than the lower limit of normal. So I won't do that to you on the test. I won't try to confuse you. I just want you to know that you're going to run into these things and you're like, well, why didn't they? And I'm like, stop you right there, because that's the beginning of driving yourself crazy in medicine. Until you're older and you're more, then you can start being someone that updates guidelines and does all that. But in the beginning, don't ask why too much unless you need to understand something, because it's not intuitive. Don't ask why. Drink blood dry. Alright. Anybody knows that reference? You're old. Alright, here, the 19s. Back in the 19s. Alright, so obstructive, yeah, we got that. suggested patterns, so again, we'll go over these. I'm not gonna take too much time to go over that. This is what your test questions will look like. So when I ask you to interpret PFTs, and this is the data I'm gonna give you. Just to orient you to this, just like our ABGs. Remember, we've already gone over this. We know this is the forced vital capacity. This is for this 65-year-old African American male. That is going to be what we predicted for this person. For the FEV1, after 1 second, right? That's going to be 3 point whatever. That's what we predicted for him, and then this is what. So this is the values we predicted for this patient. Now we give a little wiggle room, right? So 3.93 is predicted, but they can go as low as 2.99 and still be normal. We won't call that decreased until it's less than that. So this is just your normals. Then you go over here, and this is, see up the top it says pre. So there's going to be places in the report where it's pre and post bronchodilator. Right? So this was the reversibility test. You will only see post bronchodilator data in a report if there is obstruction. That is going to be a hint. So if you don't see any post bronchodilator data filled out in here, that means they didn't do it because there was no obstruction. So it's a little hint for you. If you don't see it, then think restrictive. I mean, check yourself, but usually if they only do this if there's evidence of obstruction. And evidence of obstruction would be that FEV1 FVC ratio being below the lower limit of normal, which here it is not. So the FVC for the patient was 4.39, that's above this. The FEV1 FVC ratio was 72.9, it's above this. So this was a normal. I love how they put suggested, right? In medicine, you always need to leave yourself out, right? It's just suggested. 99.9%. Alright. Alright, again, this is COPD and asthma butt heads, right? But in most cases, it's going to be, you're not going to have a patient, if it's less than 0.7, it's usually going to be less than the lower limit of normal. So it should match up. I don't know why COPD doesn't just change their stuff to lower limit of normal. All right, I will give you this chart on the test. I'll hand this to you. You can use it. It's got a ton of good information on it. For the test, I will cross this out. So you can cross that out right now. This is PFT nerd. Well, they like to, there's a time where it could be clinically useful for you, but it doesn't really help you. It's not something you need to know in terms of doing this assessment. But for the PFT community in general, it's like when we talk about sleep studies, this is how they'll report it. This is how they'll report obstruction. And then obviously it'll correlate to an FEV1. But for now, don't focus on that or think about that. The rest of it's extremely useful. So it walks you through it. A lot of students before the test will come down and just have me help them orient themselves to this. But if you go line by line and you actually read it, it'll tell you what to look at, right? And then it'll tell you if it's decreased in normal. It's a very easy chart to follow once you orient yourself. We go all the way to the left here. We've got normal FEV1 FVC. We've got normal FVC. We come down here, and we can consider that bronchoprovocation if we suspect asthma, right? And don't worry about that. But it's on the chart, right? But you don't need to memorize that or use that for anything. Restricted pattern is when the flow, right, is normal, but the volume is decreased. And then it says to determine severity. That's, again, not something that we're going to be doing on this. So you can cross that out as well. But the next step for that is typically you want to see how much residual volume. is present. Obviously, you're gonna get a CT scan, you're gonna refer them to pulmonology, all that good stuff. Maybe repeat the study. We come over here, obstructive. These are our asthma COPDs. That means that flow is decreased, but the volume's within normal limits. So this is purely obstructive. Again, I don't know why I keep that arrow there. I have to keep getting rid of that, but I'm not going to expect you to pause and do that. But I do expect you to know that if there is obstruction, we will do the reversibility test, which is basically giving them a bronchodilator. If it reverses, great. It's probably asthma. If it doesn't change it, then it's probably COPD or some other obstructive disease. When we talk about COPD, we'll talk about this gold. We still use it. We still use it when we communicate. So I'll at least explain to you what that means, so that you, when somebody says a gold 2, that you can figure out clinically what that means. And it does sort of tie into medication treatment. We'll talk about that in a whole lecture though. So just this one down here too, it's one little thing I just want to highlight. This also explains when we do get to that reversibility test and we are out in the far right part of our data trying to do our interpretation, the magic number there will be 12%. So they'll show you right out here, right? So we've already looked at this, we've already looked at this. Now we come in the middle one and we go all the way out to the right and we're looking at this percent change. If it's above 12, it's reversible. If it's below 12, it's not reversible. If it's 12, I want to do this. But you will get this, so once whatever test you're taking before this test is over, we'll reorient you to that. All right, last couple topics, sort of. Here's our body plesiomography. This is a full PFT. This is how we get our residual volume. I'm not going to say a lot more about that, but when we have a mixed pattern, when we have patients that have these mixed patterns, you really want to see what that residual volume is. You know, is it because that the lungs have been replaced by some tissue, or is it because the patient has emphysema and they've got air trapped in there? Because if the residual volume is really, really, really high, then we're looking more of an asthma. So it's useful clinically. Not a ton more I want you to really know about that. Other than when you have a patient who has a mixed pattern, and we want to get more information about the capacity of the lungs. Again, we're going to be doing bronchoscopy, we're going to be probably doing CT scans and all that, but this data is useful. This is a newer one. I'm going to make it FYI. Probably 2 classes from now I'll start teaching it because I feel like it's almost getting to where you might see this. They are doing it. It's a newer way. It's a more in-depth way. So we're talking about function, and this is like very physics, right? So this diffusing capacity actually goes a little bit farther in assessing the function of the lungs by dipping their toe into that chemistry part of it too. So it gives you a better assessment, not just the, banging on the drums, how much air is in and out, but they go a little bit further and nuance that with how is that, interpreting it all the way down farther into that loop of respiration. So another tool, another test, something you will not order, but something you may come across, and understanding that it's part of the evaluation for respiratory function. All right, we got a peak flow meter. Again, falling out of fashion, I'm not sure that Major Klein uses it, or almost Colonel Klein. I'm not sure she even teaches this in peds anymore. It is, imagine, you're doing kind of like a forced expiratory volume. They're useful for people that are trying to get their asthma under control because you can figure out what that FEV should be when they're asymptomatic. So if they start to have symptoms, it's just like the ABG. They can see how severe it is, and then they can assess their response to treatment. Did that help it? Did that improve it? Because most of our asthma action plans for kids involve them, if your symptoms don't get better, if you're still in this red zone, right, then you have to go to the ER. But if you go from yellow to green, you're good. Or if you're already green, maybe you're just having a panic attack, right? But it gives you an objective way to measure that flow of air. So I like them. I still use them in practice. I think that they're helpful. It just gives somebody a way to check it at home, because they usually don't have a pulse ox, right? We want to give people as many tools as possible to manage themselves at home, especially with chronic conditions like asthma. I always feel bad for parents having to run their kids in. Empower them as much as you can. All right, that's just an example. These are pulse ox. You love pulse oxes. If you get one of these out in the field, guard it with your life. They get legs like crazy, right? I love these things because you can move it around, right? It's not like you're dragging something over there and you're having to pull these long cords and step over them and all that. But they disappear, unfortunately. So keep this. I wouldn't call it sensitive item, but I did check it in with my narcs when I would go out in the field, just because it's really important when you have somebody come in and they're saying they're having respiratory issues, and you're like out in the middle of nowhere, and someone took your truck into town to go get snacks, so you can't transport. It's really nice to be able to put a pulse ox on somebody, get their heart rate, and figure out what their oxygenation status is. So it's a nice way to even figure out, do I have to like go commandeer something and start driving them? Do I need to get my tubes out, right? Do I need to pull my oxygen out of the corner? It might not even work because nobody checked it before we left, right? That's just, we'll have a whole day of just commiserating. Oh boy. Alright. But yeah, good stuff. The quicker and easier things are, so this is like a screening test, right? It's not an ABG, it's not, but usually the quicker and easier things are to do, the less accurate they are. So it's like a screening test for a mammogram or a pap smear, right? They're not that easy, but they're generally non-invasive. You don't need a lot of equipment for these, but you trade that off with a little bit of less accurate than you'd like it to be. Just keep that in mind. You know, these are some things that might, you're checking it peripherally, so all kinds of stuff between, you know, can infect it. In general, you're looking at ±4. Never walk in and see someone and look at like a 63 and just start like tubing the guy, like check it, turn it over, you know, like don't, you know, just, they're good tools, but be careful. Just use them effectively. But they're great, very important to have, especially in trauma, especially when you're monitoring someone. You give an intervention, you see that pulse ox going up, that's a great feeling, right? You give them the Narcan, you give them the albuterol. There's something else called the walk of life test you might hear, right? This is a patient who, you got them on pulse ox, they were on oxygen, they were in the hospital for a few days, they were satting like 82, but you treated them, and then you weaned them off oxygen, but they're not putting any demand on their body, right? They're just chilling. So they might be, you know, 93 laying in bed, but the second they get up and they start to put any demand on their body metabolically, that pulse ox will drop. So when you're discharging someone, especially if they've been on oxygen, you give them what's called the walk of life. That means you put a pulse ox on them and you walk them up and down the hallway. Still little people getting ready to be discharged, they got them out of bed and they're cruising the hallways. And we're watching that pulse ox, and if it doesn't drop, say below whatever, then they can go home. Or if it does drop, then they go home on oxygen. Either new oxygen, or you're going to be on 2 liters now when you're at home until you have your follow-up, and then we'll see how you're doing then. Because we, you know, being in the hospital, we'll talk about hospital-acquired pneumonias. That is a place we keep people alive, but not necessarily a place where we make people healthy. You want to get them out safely as soon as you can. So even if it's home with O2, as long as they have good social support, that's the better way to go in most cases. And then this, you know, Ivan Drago thing down here. So, I don't know if anyone done that? Is it cool? Yeah. I don't know. I'm always like, I don't need that much information about myself. You know, then I'll start being like, oh, you know, my twin got like a full body CT or something, and it's just been problems since. Like one of my kidneys is small, and it's just weird. And even then, woo, that was cool. If I went too fast, come see me, because I tend to overcorrect, right? I went too slow last semester. And now it's one person can put it too fast.
We have our Mupirocin here, our Bactroban topical. They put it on for 5 days, and then you can typically see this kind of clear up. Mechanism of action, stopping that protein synthesis, so therefore we don't have to continue to see the medication replicate, cream and ointment. So depending on how your patient presents, if they're very flaky and dry, the ointment is going to be the better choice for you over your cream. So you're not worried about any of this. You're worried about disease state. What am I using to treat it? Okay? I don't need you to do any of this in between. And that's on all of these when we're talking about it. All right, your acne. Understanding with this that your person, they get this pore that's gonna get clogged, they're gonna form a comedome, and now you're trying to help them. The more that they pick, the darker that their spots will become. So just make sure that you're understanding a lot of people will be coming into you because they're gonna have acne, okay? Don't remember anything from that side. When you're looking at this, the one thing that I want you to pay attention to here is that you can have bacterial colonization that is the root cause sometimes for acne. Sometimes it could also be that I just have a clogged follicle, and now that gland has all of that oil production, and now I've also formed that pimple, okay? So there's several different reasons as to why this can happen. When we're looking at our bacterial colonization, the one that we typically will see causing it is going to be our P. acnes. And remember that this was one of our gram-positive anaerobes that we had, and we're going to talk about that because there's a medication that we're going to use to try to help if this is the reason why. So, only thing I need you to remember from this whole slide is that you can potentially have that bacterial colonization by your P. acnes. Looking here, make sure that you understand that your very important counseling point to your patient is that this will not be resolved immediately once you put them on treatment. A lot of patients are going to be like, they want their face clear now. I used to be one of those people like, I have a pimple and I want it gone right now. And I'm going to pop it, and I'm going to squeeze it, I'm going to put toothpaste on it, I'm going to go and try to ask you for every single medication that you can find, and then I'm going to try it for 2 days and say that doesn't work, and I need another one, and I need another one, and then I have a collection and I start mixing stuff on myself, right? Like, that's how people are because they can see it and they know that it's there. So your thing is to talk people off of the ledge and say, hey, it's going to take us some time for us to get this under control and see which medications work, because we also don't know what the cause is. Sometimes it's hormonal as well. Sometimes it's stress, right? So you have to figure out what the issue is. So here you need 1 to 2 months before you are going to change any of their dosing regimens, before you add on anything else. Make sure that you are paying attention to how long they've been on it. Looking at these different, I guess, ways in which somebody can have acne vulgaris. So you see you're normalizing follicular keratinization. The medications that we have to use for that are going to be your benzoyl peroxide, your retinoids, and your azelaic acid, which we're going to talk about. Decreasing the sebum production, if that is what is causing them. You have retinoids and hormone manipulation. Suppressing the bacteria, we can use antibiotics, some systemics, we have topicals as well. Benzoyl peroxide, retinoids, azelaic acid, and then if it is just caused by the sheer fact of like it's an inflammatory response, then we have also some antibiotics and some retinoids that we can potentially use as well. So this is a very important slide for you to make sure that you're knowing, hey, what drugs do I have, and what disease state, well, we know that they're treating acne vulgaris, but what particular target am I trying to hit, and which drugs hit that target? So this is essentially like the mechanisms. When you're looking at your benzoyl peroxide, okay, we have several different names. A lot of people are going to know Clearasil because that one is over the counter. that you can get, and now the benzoyl peroxide comes in several different, like, almost every store has their own brand now. So when you're looking at this, the most effective topical that we have for our acne vulgaris releases O2, which then can kill some of that P. acnes, because remember we said that it was an anaerobe, right? So it doesn't want that oxygen to be around. So with our benzoyl peroxide, it's releasing that O2, and then it's killing my P. acnes, which should then make my acne decrease. This medication is very, very popular. It is very effective, but it is also very irritating, especially if someone has never used it. If they have very sensitive skin, they are going to potentially be very, very irritated whenever they use it, because it is an irritant and it does cause sloughing of the skin. So they will start to see like their skin actually like peeling. They will start to see those coming on and start to dry up, but just understand that it is a great medication. They just need to moisturize. So they will put on their medication first, and then they can put on their moisturizer after they put on the medication. You'll also see that if someone has dry spot or dark spots, that this can sometimes also help with the appearance of that, right? Because it's making them shed that layer of skin. Granted, when they get those dark spots, it's a lot deeper, but it can kind of lighten it up a little bit for some of them. Looking at our clinical use, inflammatory, non-inflammatory acne, very good if we're talking about our acne P. acnes, right? And then looking at your most effective, this is the #1 go-to that we have. Yes, you can prescribe it, but yes, they can also go and buy it over the counter. There's several different brands, so just remember to use the generic name, because this one is marketed in several different brand names, like some of our other medications that we talk about. And then when you're looking at the efficacy, we're going to talk about this because sometimes we combine it with other medications, because it is the most topical, because it is the most effective topical that we have. When we combine it with other medications, we get a better effect. Somebody had a question.
Is there like a combo with a moisturizer?
Is there a combo with a moisturizer?
Yeah.
So some people, I tell people to make it. I haven't seen one, but I also haven't worked like in an outpatient pharmacy outside the military in a while. What I tell people to do is like if they have a sunscreen bottle, to empty out half of their bottle of their sunscreen, or if they've used it, and then they pour in the tube of the medication, and then that way they're just putting it on there together, because sunscreen is also a great moisturizer, and that way they're not fogging their face, and so then they're putting them on together. But depends on the person, because sometimes I'll still just tell them, hey, keep it separate, put your medicine on first, and then moisturize after, because I want all of the medicine to get in there. But if it's very irritating, which it usually is in the very beginning, I do try to have them do both at the same time, because it burns and people will stop taking it because it is so irritating. Yes.
Which one, there's a difference if they have to use the wash?
So when you think about the wash, you're getting everything off, but just while you're in the shower or when you're standing over the sink and you're washing your face, you put the topical on and staying on there for a longer period of time. So your contact. So sometimes people use both, and it does come in both of those formulations. But you have to be careful with that, because if it's over drying, sometimes your skin can then start to try to produce more oil, and then the acne can get worse. So most people do not. It depends on how bad their acne is, but sometimes I will not start them on a topical and the wash at the same time. I will probably be like, hey, use just the wash, and then I'll add on the topical, or I'll have them do the topical first and do the wash. But efficacy-wise, I don't know, I would have to look it up, but just thinking about like the contact with your skin, I would say that a topical is better, because I'm on your face for a longer period of time, versus you just washing your face, you're washing it right off. Your adverse effects, very good, again, medication. So remember, this is like your #1 go-to when we're talking about acne for your topicals. You see that we are going to moisturize our patient, not only because this is going to be an irritant to them, but also because they have that photosensitivity. You'll see that burning or that tingling that I told you about. This does go away the longer that they use the medication, but initially, usually that first week or two, it is kind of like, it kind of stings and you're like, whew, okay, kind of take your breath away a little bit. Drying, that skin is going to be sloughing off, so again, just make sure they have a moisturizer on hand. Looking at your cautions that you have available. We do tell people sometimes to use this at bedtime. If you're doing that, make sure that they don't have dark colored sheets on their bed, because it has that, like, I think about peroxide. If you pour peroxide on something, you leave it long enough, you know how it can bleach stuff. We used to bleach our hair like that a long time ago. So this, you will see discoloration in their sheets, right? So let someone know that, because if I have black sheets, now I've laid on it, right, with my benzoyl peroxide on it all night, I can start to discolor my sheets as well, okay? Looking at your topical antibiotics that we have available, clindamycin, erythromycin. We have combo products of those two medications together. Very good for suppressing that P. acnes that they have, right? So if I know that is the cause, or if I have tried to just use my benzoyl peroxide and I didn't get a good response, now you see where I've used it in combo. And remember when we were looking at our benzoyl peroxide slide, it was saying if you're using it in combo that you usually get a better result, right? But this is not what we wouldn't typically just jump straight to this. We will try to see if a person is going to respond to that benzoyl peroxide first. So looking at these, your 50S inhibitors are back again. When you're looking at your mechanism of action, again, big thing, suppressing your P. acnes, right? And I don't want to have any, if I know that P. acnes is my issue, then I have my benzoyl peroxide that's going to release that O2 to kill it. And if that's not enough, then I add on my Clinda or my erythromycin. My use for this, right? Remember I said, yes, I get a better response if I use it with my benzoyl peroxide, but it's not my first option. This is more so for whenever I'm saying, hey, somebody is very, very severe, I can then go to this medication. We'll talk about rosacea in a little bit, this off-label use. There's other medications that we have now to where we're more likely to use those, but this is a cheaper option if somebody does not have insurance for them to use for that. Looking at your benzoyl peroxide and the combo effect of it, you see that it's kind of helping with decreasing that resistance that we could potentially see if they're using this for a longer period of time. Because it is acne, we know that it's going to take a long time, and they're taking that antibiotic and they're putting it on their face, even though it's in a low dose, they're putting it on their face every single day. Adverse effects, still have that burning, right, because I still have my benzoyl peroxide portion of it, but you can also see the potential of C. diff the longer that they're on it, okay? Very, very low chance of that happening, but again, because you're looking at your Clinda and your erythromycin, same thing that we talked about last semester, C. diff is again, right? C. diff is still. Looking at our systemic antibiotics, we have minocycline and our doxycycline, which are our tetracycline. And so after I have tried my topicals and those have failed, then you will see that I am moving on to my systemic antibiotics. These are usually given in a lower dose than what we're talking about when we're looking at like treating an infection, okay? So they're taking them at a very low dose and they are taking them for a longer period of time. Good against our acne vulgaris again. Making sure that your patient understands if there are any old pimples that are on their face, it's not going to be doing anything to those, but it's going to be preventing new ones from coming up. So they're going to have to wait for the ones that are already there to resolve before they start to see like the effect of the medication. So again, patience is the big thing with this. Patience is key. Slow onset, 3 to 4 weeks, can be up to 6. So just, for before they see an effect, and then whenever we're leaving them on this, they're going to be on these medications for about 6 months before we try to take them off and escalate to something else if we're still not seeing a response from them being on these. So again, minocycline, doxycycline, dose is typically lower than what we would see if we were treating an infection. Takes a long time for them to work, and then we're also going to say, hey, I'm not going to let you stay on these medications for a very long time because they're an antibiotic, and then looking at the fact that all of their old gunk that they have is going to be there, and it's just going to start working from within and trying to make sure that no new ones come up. So they're going to have to let those resolve and then they should start to see a decrease in new papules forming on their face. Your retinoids, I love retinoids. Retinoids are your vitamin A analogs. They decrease your sebum production that your P. acnes kind of feeds off of. So they are going to decrease that. They're going to decrease inflammation because they stop like the inflammatory process. Remember that when we're talking about these, we looked at this a little bit when we're looking at we'll talk about our acne when we talked about our acne vulgaris. So now when we're looking at this, we're like saving these as last line for acne, okay? Don't go to these first. They are effective and they are great and we do have them, but try not to say I'm going to go off and use these first, because what is my best thing that I can use for my acne vulgaris, my topical? Benzoyl peroxide, okay? So try that first before you go on to something like this. So if you have inflammatory or non-inflammatory, right? So that's saying it's not my acne vulgaris because of my P. acnes, but like just a non-inflammatory process, then you can see that it's used first line in that situation. Adverse effects, same things that we kind of already talked about with our benzoyl peroxide. So initially, whenever they start this, again, you will see peeling, you will see irritation. Some people experience redness. So again, medication first, moisturize after. Some people will see initially that their dark spots start to get darker. There's also the sunscreen needed because again, the photosensitivity. So you see a lot of these drugs, sunscreen is going to be very important. Also, if they do have dark spots, sunscreen helps decrease those dark spots getting darker from the UV hitting those dark spots, okay? So like sunscreen is helping with a lot of things. Looking at your pustular flare. So this is very important to tell your patients because again, this is the appearance of their skin and they're trying to clear it up. But what happens in that first couple of weeks is that they will have a flare that can kind of make it look worse because it's trying to get all of that, all of the stuff out of their face. Whereas before, remember we said, hey, I'm gonna leave all of your old stuff with my systemic antibiotics, but I'm gonna work on your new stuff. This is saying, I'm trying to get rid of anything that you have. So initially, I have that flare, potentially, okay? So make sure that you're letting them know. Use in pregnancy, not recommended, all right? Most of the time, if you have a patient who is taking a retinoid, just make sure that they know that they need to stop it. Your tretinoin and adapalene category C, whereas your tazotretine and your isotretinoin are category X. So remember, if you see X, that means absolutely not. But again, we still don't use these. I do want you to know the difference between category C and category X. Because if I'm trying to become pregnant, I can potentially be taking my category C, but if I'm trying to become pregnant, I should not be anywhere near X at all, okay? And then looking at this, your retinoids and the frequency of you having to use them day and night because of the degradation. So again, that photosensitivity that we were talking about, just make sure that they're wearing sunscreen whenever they're using this medication. And then warn them about the dryness, make sure that they have something to moisturize their skin. Here are our topicals that we have. So you have tretinoin, adapalene, and your tazotretine. Looking at this, you see that I have several formulations. Just know that you have several formulations that are available. You see that I can also use these in combo with my antibiotics and my benzoyl peroxide. So again, just helping increase the effectiveness of using either of those medications alone. So it doesn't mean that I have to initially start with both of them, but if I'm not getting a response from one, then I can add my combo product. You have your adapalene, which is now over the counter, or your different. So make sure that you're understanding this I need a prescription for the most part, and then these, I can go and I can buy this at Walgreens, CVS, what have you, okay? Better tolerated, you'll see that the side effect profile isn't as bad and they're just as effective as you using the tretinoin. So an option for you to have there. And then your tazotretine, you see that this one is the one that's the most effective, but you see that we typically are going to be using this in our patients who have psoriasis. Because it is so effective, think of it as having more irritation, like more side effects of that drug because it is more effective. to put those together. So your tazarotene, which category was that? No. Okay, and then your adapalene and your tretinoin, should I use them if I'm pregnant? What about my tazarotene? Can I use that if I'm pregnant? Okay. So none of these if I'm pregnant. If I'm trying, I definitely don't need to be around my tazarotene. Okay. Your isotretinoin or your Accutane. This is an oral medication. This is like an escalation because I'm not responding to anything. You've tried all of the other medications. This could also be for like more moderate to severe like cystic acne, or again, your patients who have failed any of your other medications that you've been trying to give them for your acne vulgaris. There is what's called an iPledge program. What iPledge is that it's a REMS program to say, hey, we need to make sure that the patient, the provider, and the pharmacy are all in the loop, and the patient is counseled on the seriousness of this medication, monitoring that's required while they're taking the medication, and the fact that they cannot get pregnant while they're on this medication. Okay? So contraindicated in pregnancy, 2 negative tests that are spaced 30 days apart before they're starting therapy, because they're trying to definitely make sure that that patient is not pregnant. And then while they're on treatment, they need to be on 2 forms of birth control the entire time. Okay? So 2 pregnancy tests, 2 forms of birth control the entire time that they're taking this medication, or they are abstinent. If somebody tells you that, you just make sure you prescribe contraceptives. Okay? Also, we have condoms for free almost everywhere in the hospital. We have them in the pharmacy as well. Okay? So again, they're going to use this while they're taking the medication, and then for 1 month after they have stopped the medication, they're going to also still be practicing with those 2 contraceptives, because that medication is still going to be in their system. Adverse effects, when I tell you dry, like we were talking about dryness with our other medication, this medication will dry you out. Your lips, your skin, everything, okay? So make sure that you're telling your patient they need to drink a lot of water and they need to moisturize themselves very well, okay? Lotion, face, chapstick, like in their pocket all the time, okay? We have patients who come in and their lips are so dry that they lose the color around their lips, or they're bleeding because they're so dry and they weren't aware and they didn't have any Vaseline or anything for them. So just again, dentists, they give away chapstick for free. We also have petroleum jelly that you could prescribe the patient if you prescribe this also. Nosebleeds are also very common because, again, just think about everything just drying up, okay? When we're looking at your darkening of the skin and the photosensitivity, just think about those patients who have dark spots. It is a potential that initially they do get darker, but over time, because their skin is so dry, it will start to flake off and you'll see them sometimes lighten up as well. Alopecia, hair starts to fall out the longer that they're on them, brittle nails, like several things. So for the most part, with this medication, if you can put them on it and hopefully keep them on it for a short period of time, of course, the better. But if they have very severe acne, you will see some people on this medication for a pretty long time, okay? There are different labs that you'll have to bring them back in for. You like have to check their liver, you keep doing their pregnancy test, and they have to come in every single month to get this prescription, okay? So this also doesn't have details on it. Your depression and suicidal ideation, increased risk of that, so make sure if the patient has underlying risk, then we're checking in with them also. Acne rosacea. I will tell you what they have, okay, so just make sure that you're looking at that. And then here, think about like their skin is just red and there's no real reason why their skin is red. There's no comedones or like there's no pimples or anything like that. It's more so like they just have a rosy appearance to them, rosacea. Make sure that they're avoiding things that can dry out their skin or cause that astringent type of effect, because they're already red. Now you're making it worse. Alcohol is another thing that can also make their rosacea worse as well. So some people who have rosacea, whenever they drink alcohol, you'll see it happen pretty quickly to them as well. So just make sure that you're looking out for this. A lot of your natural oil, same thing. This is all I want y'all to know is what to avoid. again, I'm gonna tell you what they have, so you don't need to worry about all that, you'll learn that later. Different therapy that we have, okay? So you have your topical therapy that's available, and what we're trying to do is we're trying to say, hey, I want to help with the appearance. Sometimes with these medications, depends on what's on our formulary at the time, they may need a prior authorization, they may not. This continues to kind of go back and forth. So you have your topical metronidazole that comes in a cream or a gel. This is what we like to use, especially if they have those papules that are present whenever they have their rosacea. Your azelaic acid or your phenacea, this one is for your mild to moderate patients. Your sodium sulfacetamide and sulfur, this one is a topical, and we can also see it used for acne, but it smells really, really bad. So a lot of patients don't really love to use it, but it does work. And then your bromonidine or your Muvaso, this one is one that kind of goes on and off the formulary more often than any of the other ones. So this is for your patients who are more persistent, like they always have those red rosy cheeks no matter what they do, and more of these medications aren't working. That's usually when we'll try to go down to your bromonidine.
For a lot of these, are we prescribing like one or two, and then if we need to add a third, then we'll add the third on the list, or are we giving them all four?
It depends on how severe your patient is. So if I ask you a question, you're usually starting with one thing. I always like to, in any disease state, try to start with one if the guidelines say that I can. Because if something goes wrong, I know where my problem is. I can always add, but then if I start two things, I'm like, well, which one do I take away? So sometimes we'll freak out and we'll take both away, and now the patient isn't treated. So in situations where I can, I like to add like one thing. When we can't, you know, you're like, hopefully nothing happens. So if you have a question for this, it's gonna be like, here's this disease state, how do you treat it? What option do you have? There's only very few that we'll go through where one is gonna be better than the other. So if I give you a cream versus giving you an ointment, and if I'm telling you like a person is very dry, then what are you going to pick, the cream over an ointment? So you would pick your ointment, right? Because your ointment is going to also help hydrate that. So it depends on what the disease state is. Because if I told you I have acne, I'm not going to put ointment on my face. So like, it will be, I don't want to say it will be obvious. It will be appearance. You will know what to do.
It'll be one of them.
Yes, it will be one of them. Your azelaic acid, hopefully, because you know sometimes I give y'all two right answers. Yes.
Just backtracking a little bit, man. For Trent, for Trent, do you kind of take her or like have a hard cutoff of 6 months for them to like?
The isotretinoin?
Not the iso, just the regular. The
tretinoin?
cream, yeah.
So it depends. I can start responding after a couple of months, and I can be off of it. Even with isotretinoin, right? You can have somebody that's on it for 3 months. You can have somebody that's on it for a year. Like it varies.
Okay.
It is yes. It is okay with the tretinoin. Once you hit that top, like your 6 months or your like a longer period, you try to always take people off. When we talk about steroids, we'll talk about the same thing where you try to give them a break, their body a break, and then you can put them back on it. So as long as they had a break from it and you're not pushing them all the way through, you should still see a response. That what it's meaning is maybe that medication isn't effective for them. Like it's a treatment failure, so then you need to move to something else after that point, or add on to. Then I have now two things that I'm adding on to it.
Like if you have a patient that I guess is using the Trent 6 months, they're seeing results, but then they stop using it and acne shows up again. Tell them to take a break a little bit and then try it again.
Try it again.
Because it was effective.
Because it was effective. But you're not gonna leave me off of it for 6 months. You'll probably leave me off of it for two weeks and then put me back on it again. So I won't ask y'all questions that way. It'll just be like a hard, like, hey, this is what you do. Because practice-wise, there's a lot of different ways that you can manipulate it and kind of skirt around some of these maximum durations that we have. Okay, so your azelaic acid or your Azelix. Mechanism unknown, but possibly what they think it is it has antimicrobial effects and it has those keratinizing effects, less toxic than our retinoids, which is great. We don't like toxicity. For this, you see that I have clinical uses for acne and I also have it for rosacea. My rosacea is a foam or a gel, whereas my acne is going to be a cream. When I'm using this for acne, this also sometimes goes back and forth for a prior authorization. If you're using it for rosacea, you're usually okay. If you're trying to use it for acne, that's where sometimes it will ask you for a prior auth and see if you started other medications before that. See that it's pretty comparable to your tretinoin and your benzoyl peroxide, so it's a good option for you to use. But again, the thing is going to be your prior auth. Also, you see that this one, well, I'm going to have this on you. This one, you can use this in pregnancy. It's a category B, I believe. So that was a little bit different than how we were talking about some of those other medications. So our big thing here, we have less toxicity and it's just as effective as some of our other medications. Adverse effects, we can still have some stinging, some burning that's associated with it, hyperpigmentation in your patients who have darker skin. So essentially what that's saying is that I can make their skin darker in some areas. I can make if they have marks from their acne, I can make that darker in some areas. And some patients, they respond perfectly fine to it. So just make sure that you're letting people know that, because nobody wants dark spots. And then these were our two formulations, your Azelette and your Finacea. Both of these are azelaic acid, 2 different brand names for 2 different indications, okay? Looking at your bromonidine or your Muvaso, this one, again, is one of those medications, alpha-2 adrenergic agonist, that's going to help decrease some of that vasoconstriction. So if I can decrease vasoconstriction, what I can see is that my redness is going to decrease. That's my problem in my rosacea. Whenever you talk about this medication, make sure that you understand that it's probably going to be a little bit more work for you. It may require a medical necessity form, and it may also require a PA for you to fill out. So if you order this, make sure that you're also checking the TRICARE formulary lookup tool to say, hey, do I need to fill out a prior auth, or do I need to fill out a medical necessity? Because if you send them to the pharmacy, we still can't fill it, even though you ordered it, if those aren't completed. So you'll still have to complete those and send them to TRICARE before we can even process it. Okay. Your clinical use for your persistent rosacea in your patients, and then looking at your adverse effects. You have some patients where they will experience flushing, but it does go away within that first 30 minutes of them applying it. Make sure that they're washing their hands. And then you can also see that systemic blood pressure lowering effect occur. This is not something that is very common, but remember, because I'm decreasing the vasoconstriction, I can therefore decrease my blood pressure. So that's how you see that, that effect occurring. All right, our psoriasis. So again, I will tell you what they have. This is a very debilitating, some people have a lot of mental health type issues around this as well because of the appearance of their skin. There's no cure for it. It is an autoimmune disease that is happening to your patients, okay? So just make sure that you're understanding, again, I'm going to tell you what's wrong, and you're going to say, hey, this is the drug that I'm using. Before you get to your medication, I need you to understand your mild to moderate versus your moderate to severe. I will again tell you if they are mild to moderate or moderate to severe, but I just want you to know what I'm talking about, because then that can help you choose the correct answer. So my mild to moderate means that it's not extensive. It's less than 5% of coverage on my body, and I can do a topical steroid, and I may or may not need to have UVB phototherapy. If I'm looking at my moderate to severe, more than 5% essentially of my body is involved in my psoriasis, and I'm going to need a combination of my topical agents that I'm going to have, and I'm going to need that UVB phototherapy to try to help decrease those plaques, and I can potentially also or have systemic treatment as well. Okay, so make sure that you're understanding, like with the UVB, essentially what that's doing is it can slow the rate of the skin cell production. So that's why we're combining it with the treatment that we are going to give our patients for psoriasis, because they have those plaques that build up on their skin. So we're trying to decrease how thick those get. Here are all of our topical agents that we have available for us. So steroids, coal tar, your vitamin D3 analogs, which we'll go over, Tazarotene, which we've seen, your TIMS, which we've seen, and then that UVB phototherapy. Remember, If I'm mild, I may need it. If I'm moderate to severe, I do need to add it to this therapy. I have oral agents that are available, as well as some of the biologics. So you have your acitretin or your Soriatin, cyclosporin, apremilast, methotrexate, adalimumab, infliximab, and etanercept that we can use. What they are thinking is that vitamin D may be linked to increased flares in some of our patients. So just paying attention to kind of all of the different options that you have when we're talking about treating psoriasis, and understand that this is a very, very hard disease for you to kind of treat and manage. We will get into all of these. Well, let me just do a topical steroids and then we'll finish also. I'm sorry, real quick. It's gonna be quick because we're gonna talk about this too much. So remember on that first slide where we said it was less than 5%, and it said that was your mild patient, right? And it said topical, your topical steroids that you have. So your mild to moderate severe, or so your mild to moderate psoriasis that you can use to kind of help treat and calm down that thickness that is going to continue to build up in those plaques that continue to build up. Big thing that I want you to remember here, your efficacy is going to increase as you increase the potency. So the higher the potency, the more likely you are to see the results that you want to see for your patients to go back into remission from that flare that they're going to have from their psoriasis. Make sure that you're also looking at the fact that your side effects are also going to increase with your potency. And then looking at your limit of use of your very high potency steroids to 2 to 4 weeks. We're going to have this reiterated several times. So make sure that you're understanding that even if I still have my flare, you're going to take me off. You can treat me with another medication, and then you can put me back on that high potency steroid. You could also take me and put me on a lower dose, a lower potency, and then put me back on my high potency. With our high potency, if I'm staying on it for a long period of time, you're likely to see those systemic effects that we talked about with our steroids. Okay, we'll start.